Welcome, everyone. I'm Maria Alonso, and it is my absolute pleasure to introduce the speaker today. This is part of the Clinical Culture and Diversity Series, a partnership between the Office of International Programs, the Office of Diversity and Inclusion in the School of Medicine, and the Office of Diversity, Equity, and Inclusion at KUMC. Quinn Jackson, MD, MPH, is a board-certified family physician in Kansas City, Kansas. He attended Tulane University School of Medicine and residency at the University of New Mexico. They spent 2 years as a full-time abortion provider in Kansas prior to joining the University of Kansas. His clinical work focuses on trans medicine, primary care for LGBTQ+ and gender diverse care, full scope sexual and reproductive care. He's an openly queer trans man with interest in increasing queer content in medical school and family medicine residency curricula and mentoring trans trainees. Quinn believes in operating from an autonomy-focused reproductive justice framework in all spheres. True liberation will come from within our communities and through collective work, which will require a fundamental restructuring of our healthcare and medical education system. Without further ado, I am so excited. Thank you so much, Dr. Jackson, for agreeing to provide this professional development for all of us and for all the work that you do. So without further ado, I'll let you take it from here.
Awesome. Thank you so much for that wonderful introduction. Yeah, I'm here to talk about working with trans and gender non-conforming people. So we'll go through some slides and there should be some time for a discussion and questions at the end. And forgive me, I didn't ask, do you want me to share my screen or is someone else going to control the slides?
All you have to do is tell me next and your next slide will appear.
Perfect. Okay, we'll go ahead and next slide. So these are just a few of the objectives today. We'll kind of go through some background theory about gender and how it applies to medicine, as well as going through some health disparities stuff and history in medicine. Next slide. So before we begin, just some very basic definitions. Gender identity is really a internal knowing of who you are. It is really a deeply personal felt identity that is kind of hard to explain to folks who haven't been through the process of questioning gender or not being sure of who they are. It can feel very foreign to and know that other people go through that or experience that. Importantly, it is very different from anatomy, which is essentially sex assigned at birth, right? When a baby is born, we look at their genitalia and kind of describe them as a boy or a girl, but that is not, appropriate or true for everyone. It's really different from chromosomes, right? That can lead to particular types of anatomy. Very different from sexuality, which is who you're attracted to romantically and sexually, not who you are as a person. And it's different from gender expression, right? The way that we dress, the way we do our hair, and of how we move and operate through the world. Just by looking at someone, you can't really know who they are inside or how they feel about themselves. Next slide. So within kind of a medical framework, this is often how we conceive of gender. This is really a concept or a way of thinking about gender that originated in Western Europe in the 1800s or so. And this is what we mean if you've heard phrases like the binary, the gender binary, this is what we're referring to. So it's essentially a system of 2 checkboxes. You have one option, you can pick one option from female or male. And even when we think about people who are gender diverse or who do not necessarily identify with their sex assigned at birth, it still is thought of in a very binary way, right? You can be cis or you can be trans. Cis is when it's basically biochemistry. Cis is when your gender identity aligns with your sex assigned at birth, and trans is when your gender identity does not align with that sex assigned at birth. But that's not necessarily like the most inclusive way of conceiving of gender. This model doesn't really apply to everyone in the same way. Next slide. So this is I think this kind of image and graph is a much better way of thinking about gender and identity. So there's a very long history of diversity and gender and sexuality in all different cultures throughout all of time. As we talked about, the kind of current conception of it in Western places started back in like the 1800s or so. But I really like this graph because even among cis people and among trans people, what it is to be a man or a woman or to be non-binary, which is not identifying fully with either of those genders, really looks different for different people, even within the same identity category, right? So if we took a group of women, cis women, I think what it is to be a woman would mean different things for different people. And so no one's located in exactly the same space on this 3D graph, right? It's all kind of different shades of similar experiences. Next slide. So gender is a social construct. And when we talk about social constructs, I think particularly in kind of science-based fields and in medicine, there can be kind of a reaction that if something is a result of social interaction, or we're saying that it's a social construct, that we're saying that it's not real, which is not true, right? So there are all kinds of social constructs that are very real. They just mean different things in different places, and they change with time and circumstance. And they're really the result of, humans being social creatures and interacting with each other. They're not the result of some inherent biology or gene. Some less politicized examples are things like time and money, right? Like different cultures use different money throughout time. Different cultures have used different items to define worth and trade. Different societies have different calendars and measure time in different ways or conceive of time in different ways. And the same can be said for gender and sexuality. Next slide. Unfortunately, there is a very long history in our society of pathologizing queerness of any kind. This really is deeply rooted in white supremacy values from Western Europe, and they were disseminated throughout the world via colonization and really violently imposed on other cultures. In a US context, one of the biggest examples are like the Native boarding schools in the US and Canada that really violently imposed like a Western idea of a gender binary on Native people. And essentially tried to prevent anyone from operating outside of that kind of construct. There also is a long history of sodomy laws, which essentially outlawed the type of sex that a lot of queer people have, as well as dress codes. So people could be arrested simply for wearing clothes that didn't align with the sex they were assigned at birth or the gender that police thought that person should be. Unsurprisingly, those kinds of laws were applied in disparate ways depending on who the person was. People who occupy multiple oppressed identities often were, these were used against them in more harsh ways than they were against more affluent white people. Next slide. So medicine in the US is also primarily a result of kind of Western European thinking around the same time. So we see that we're also really deeply rooted in a lot of these kind of binary structures and ways of thinking, and have a very long history of pathologizing any kind of difference or any kind of deviation from societal norms. And we even see this in things like the DSM, which is the, essentially the text that we use to define and diagnose psychiatric illnesses. that often certain criteria are that you just don't fit in to, to norms, or that you can't function within norms. And often that inability to function within our systems, the blame is placed on the person who is not able to do that, as opposed to critically looking at the systems that are violently impose things that are not necessarily appropriate for everyone. Throughout a lot of our history in medicine, we've used like medical treatments that value assimilation over accepting people for those differences. So things like conversion therapy, trying to force queer people into straight identities or into cis identities, as opposed to just accepting them for who they are. And those have been, extremely violent and invalidating and harmful to a lot of people. Next slide. So in terms of, specifically in terms of kind of gender diversity and trans folks, in the US, some like history, Harry Benjamin was an endocrinologist who started essentially a trans clinic back in the 40s, and was really one of the kind of main drivers of trans medicine and hormone treatments and kind of assisting people in living the life that they want to live. But there were a lot of flaws in how that was carried out, or a lot of harms that were done to people. This is a picture of Christine Jorgensen. She was one of the first people to have gender affirming surgery in the US. And that happened in 1951. I think a lot of people are not aware that this has been going on for really quite some time now. Not as long as some other forms of medicine that we have, but it's certainly not something new or something that, doesn't have an evidence base and doesn't have a long history to it. In the 60s through the 80s, gender affirming care was essentially like more widespread. Dr. Benjamin's clinic, I think, was in New York. And so later, with more time, we saw more clinics popping up in other places, primarily on the coast, but also in places that you wouldn't expect, like Texas and the Midwest. However, the way that people were able to access this was really quite prohibitive. And one of the terms you'll hear a lot is gatekeeping. And so that essentially is when the physicians and people with power were the ones who decided who was appropriate for this kind of care and who was allowed to live as who they are. Some of the criteria that they use to define that, I think that we all would see as pretty harmful these days. So some of the things they would do is they would essentially decide if someone could pass or not, or the likelihood that they could pass, and the likelihood that they could pass as an attractive cis person. And those who they thought could pass, they would allow to have treatments, and people who they thought might not pass were not allowed to have treatments. People really were kind of forced to fit the man trapped in a woman's body or woman trapped in a man's body type of narrative. That really isn't something that a lot of trans people identify with, right? Gender can be much more complicated than that. And so a lot of people were not able to access care who really should have been allowed to access care. Some of the other ways that this was harmful, they would only allow people who were straight to access care. And what I mean by that is if you were a trans woman who is someone who was born a man, but who is a woman, if you were not attracted to men and able to exist as a straight person after medical treatments and medical transition, then they would not allow you to access this kind of care. It also, of course, was not something that health insurance covered, so you had to be affluent enough to be able to afford these things. And so there was just a lot of problematic application of these treatments for certain people over other types of people. Next slide. I think we would be really remiss not to kind of acknowledge a lot of like flaws within our own movement as well in terms of like the trans rights and queer rights broadly. So throughout time and history, queer femmes of color, and that includes cis women and trans women and just trans feminine people, have really been on the forefront of like pushing our movement, pushing our society to be more inclusive and to, you know, allow us to have rights and live the lives the way that we want to. These particular women, this is Sylvia Rivera. I love this picture because she's holding a little cat. And this is Marsha P. Johnson. These are both trans women, trans feminine people who lived in the New York area and around the Northeast in like the 60s, 70s, 80s. And they're two of the people who are kind of well known today, but I mean, there are thousands upon thousands of trans women of color who have been pushing our communities to be better throughout history. We just don't remember them because they're not the type of people who are valued in our society. So often when you read about or hear about kind of queer rights or you know, like gay rights, it's a lot of cis white men who are the voices who are listened to or the voices that are held up. And I just think we should be very intentional about knowing more of our history and acknowledging like the Black and brown queer women who have really pushed us to be better. Both of these women are kind of well known now, but died in relative obscurity, so didn't even, you know, get to see how their work really positively impacted our communities. Next slide. Next, we're going to dive into some health disparities that exist among trans people, and I think it's very important to frame this in terms of like where, like the cause or the root cause of a lot of these health disparities, similar to like racial disparities and class disparities that we see, are not because people are trans. There is nothing inherently about being trans that makes you more likely to have mental illness or more likely to be unemployed or, you know, not able to rent housing. These are really results of discrimination and structural violence. When I say structural violence, I mean the way that our systems are set up to be harmful to people and to not give certain people protections unless they fit kind of a dominant norm in our society. And of course, within all of these disparities that we'll talk about, they are more significant for people who occupy multiple oppressed identities. So we see racial disparities and we see class disparities among all of these other disparities that we will talk about. So most of this data is going to come from the 2015 US Transgender Survey. This is the most up-to-date kind of national survey of trans folks. It's about 30,000 trans adults who responded at that time. They were supposed to do another one in 2020, but COVID kind of preempted that. So they just collected data this year, last year and this year. So hopefully in a year or two, we'll have that report and have some more updated data. But this first graph, I think, is really important to see the kind of psychological distress that trans people live with on a day-to-day basis, right? Just from like trying to exist in this world as it is. And they're really significant. This kind of clear bar are the general US population from a similar kind of national survey. And we see anywhere from 4 to 10%, and trans folks really are like orders of magnitude higher than that. And we see that particularly among sort of young trans folks who are under 30. And truly, this is just from like having to exist within a society that is so harmful to us. Next slide. Within healthcare specifically, some of the stats are really appalling. So this was back in 2015. A third of people who had sought healthcare in the last year had experienced discrimination or mistreatment. This ranged from people misgendering them, using the wrong pronouns, refusing to use their appropriate name, you know, trans people having to explain themselves or teach their providers about who they are, what their anatomy is, you know, as opposed to their healthcare providers just having an understanding of what trans people are, to much more serious experiences like verbal, physical, and sexual assault from their healthcare providers. We saw that a lot of racial disparities within this. Indigenous folks and Black folks had kind of the highest rates of experiencing these compared to white people. And then the last stat is really quite concerning, that about a quarter of people who responded just did not seek any kind of healthcare out of fear of being discriminated against or mistreated. You know, if we saw that among really any other population, we would be extremely concerned that a quarter of people just aren't getting care that they know they need, including emergency type care, just because of fear. Really, both of these numbers should be zero for anybody out there. Next slide. So this graph is about family rejection, and this is anyone in their family. So this was grandparents, aunts, uncles, cousins, parents, siblings. You know, how many people experience someone in their family essentially refusing to have them in their life anymore, simply because they came out as trans. And, you know, more than half of people in every age group experienced that. And older people, or people who come out at an older age, experienced that more than younger people, but younger people still experienced it to a pretty significant degree. And, you know, depending on who in your family does this, it can be, you know, more damaging than others. Also, when in your life this occurs, right? But still extremely damaging to have our like attachment relationships and relationships that are supposed to be safe and loving, essentially just completely ripped apart because you want to live as who you are. You know, it's hard to, I don't know, it's hard to kind of put that in a medical framework, but that is like an extremely damaging and traumatic experience to go through. And most trans people have experienced that once or more times in their life. Next slide. Housing instability is a really big problem for trans folks as well. You know, this particular bar graph is about people who were kicked out of their house by their family after they came out, and a significant proportion of people are rejected from their home and then have nowhere to go after coming out. And we see racial disparities among that as well, the highest among Native folks and Middle Eastern folks. Kind of a double whammy for this problem for trans people is that our shelter systems are extremely gendered and for the most part really not welcoming of trans people. So often really not a safe space for them to access. So when they go, these are some quotes that you can read, but essentially when they go to shelter spaces, they're either told that they can't be helped because they're trans, or they have to navigate like which gendered sphere they're going to be in. And that can be a really scary and dangerous experience for a lot of folks. So they can open themselves up to physical and sexual violence, depending on, you know, where they have to be housed, or they can make other people in the shelter uncomfortable and then ask to leave. This absolutely happens in our like domestic violence shelters as well. You know, a lot of trans people and queer people are told that they can't be helped, or they get kind of less interventions, less services than other people, because the organizations don't know what to do with them, or, you know, haven't built their system to be inclusive of queer people. Next slide. Unemployment is a huge problem because of discrimination. You know, you can see the bar graphs here that we experience much higher rates of unemployment. Part of that is from discrimination, and part of that's from the effects of things like housing instability, right? I mean, we see that with everybody. If you're not stably housed, it's really hard to hold down a job and do all the other things that society expects us to do. And there are really disparate protections for employment. There are some federal protections. Here in Kansas City on the Missouri side, there are some protections. To my knowledge, there are not state protections in Kansas or Missouri. But active discrimination still happens all the time in terms of people coming out at work and being fired, or people advocating for themselves and asking to be called the right name or have the right pronouns used, and then have their employment essentially terminated for that. Next slide. So we also see big class disparities in access to healthcare and gender affirming care specifically. This map is from September and actually has changed a little bit since then, but for the most part is accurate. So the states that are in green have Medicaid policies that explicitly cover gender affirming care. And the states in orange have Medicaid policies that specifically exclude gender affirming care. And the states that are in that kind of like yellow off-white don't have any explicit policy. So it kind of depends on the particular Medicaid, the insurance carrier and policy that people end up with. We know that this is going to impact people of color more, right? Because they are more likely to rely on safety nets and Medicaid policies. So we really see some pretty significant geographic and class disparities in who is able to access care and who can't. This is, of course, really damaging just on a personal level if you don't allow people to be who they are and live the life that they want to live. But it can also be really damaging in terms of like personal safety and opening people up to violence. Trans people experience violence at much higher rates than cis people do, both sexual violence and physical violence. And the ability to access gender affirming care is important to allow people to be who they are. But also to a degree allows people to like pass as cisgender if they desire to, but can give people the safety of not being found out by strangers on the streets or strangers in a Target if you want to use the bathroom while you're running errands. We really, I think underestimate how important it is for people to be able to access this kind of care, just to be able to live their life in like relative safety on a day-to-day basis. Next slide. So one of the big things that I want you to take away from this presentation is that gender in any form is not an illness. We all have it. And it just looks different for some people than it does for other people. Yet we are essentially kind of in a position as providers of having to diagnose people with an illness in order to provide them medical care to access medical transition. So the way that looks today is that there's a diagnosis called gender dysphoria or gender incongruence in the DSM that we have to diagnose people with to get services covered. And it's tricky, right? Because for other queer people, like if you are just a like gay man or lesbian out there, you don't have to see a physician in order to be who you are, or I should say, see a healthcare provider in order to live your life and be who you are. But to be trans, we kind of do, right? We have to use medications and surgery to change our bodies to align with what we want to be. And so the way our system in the US is set up is that we have to diagnose people with illnesses and use codes to have our visits covered and have labs covered and have medications covered. So it ends up being a kind of uncomfortable position to have to diagnose people with this, and kind of out of the scope of the talk today about how to do that in an affirming way. But I think there are ways to have conversations with patients to make sure that they meet some of those criteria so that you're appropriately kind of diagnosing and documenting, but without stigmatizing them. The timing of this is really interesting, actually. Back in the 60s, 50s, 60s, and early 70s, homosexuality was in the DSM, so it was considered a mental illness, and there was a lot of external and internal advocacy from queer people and a lot of gay psychiatrists within the APA to get that removed from the DSM. That happened in 1973. And then when they updated it in 1975, they added transsexuality or gender nonconformity to the DSM, and it stays there today in a certain form. The other big thing to take from this is that it is really complicated and traumatic to exist as a trans person in our current society, particularly now as we're seeing so much of our care and our existence being politicized. But really that systematic exclusion from society and all of those kind of familial ruptures that happen lead to a lot of trauma and complex trauma that can manifest in, having significantly higher rates of mental illness, of substance use and misuse, all kinds of things that can make it just a little more complicated to take care of this population than it is for folks who haven't gone through those kinds of really traumatic experiences. Next slide. So our role as healers in terms of caring for everyone that we meet, but particularly caring for trans and gender nonconforming people, is to meet people where they are, right? And not make any assumptions about who they are, what they want their body to look like, what they want their life to be like. And to a degree, letting them control what they want their body and life to, or excuse me, not their life, what they want their body and their medical transition to look like. Of course, we want to do that in an evidence-based and safe way. And so a big part of our job when we're doing this care is to kind of make sure they're aware of risks and benefits, and also make sure that we're doing things in a way that will keep them medically as safe as possible, but as much as possible, letting them control that process. And really helping them kind of live the life that they want and value. And I hope that we're doing that for everybody that we see, no matter who they are, but particularly for these folks. And to remember that trust is an earned process. So every trans person that I know, that I take care of, and that I know personally, has had negative experiences in healthcare. I think probably most people have had negative experiences in healthcare, unfortunately, but particularly in this population. So the first time that you see trans people, it is not uncommon that they are guarded and mistrustful of you. And so it's important to invest in that relationship and getting them to trust you. There also is just broad mistrust of the medical system because of the long history of how we allowed trans people to access medical transition and how we controlled that. And so there is a huge amount of out of necessity. In decades prior, we had to rely on ourselves and on our community to be able to access medical transition and live the life that we wanted. So there still is a pretty big amount of that in terms of medical knowledge sharing online, in Reddit forums, in community groups. And so I think a lot of healthcare providers can feel off-put by when patients kind of question our plan of care, or bring us evidence or questions that come from non-medical sources or from the community. But that's absolutely something that will happen among trans folks, as we had to do it that way for so long. And widespread access to care and to health systems that have talks like this and anti-discrimination policies is just not something that has existed for very long. So really investing in kind of earning their trust is one of the most important things that we can do as healers. Next slide. Also, some pretty significant systems changes are needed in a lot of places. Thankfully, here at KU, we have a lot of this stuff going already. And that includes like institutional non-discrimination policies, systems in place to ask all patients what their gender and pronouns are, because we can't assume looking at anybody what it might be. And for a lot of folks, they aren't super excited to share that with us. They don't want to be the people to ask or to tell us those things. They want to be asked. But also making community partnerships, making sure staff and providers are trained in how to interact with this population, and a lot of state and federal policy level changes that need to be made to make access to care, more equitable across populations and geography, and policies outside of healthcare. We saw all the problems with housing and unemployment and all kinds of experiences of discrimination that we face. Next slide. That is all that I have planned. I don't know if anybody has questions or thoughts they want to share. I don't think anything came up in the chat.
Thank you so much, Dr. Jackson. But yeah, we have some time for questions or comments.
Feel free to throw them in the chat too. I know unmuting is stressful.
Well, I'll unmute. Dr. Jackson, thank you so much for this presentation. It's been really wonderful. My question for you, and you may or may not have an answer, but I assume you have an opinion. When you were discussing the need to diagnose people in order to provide them care, what would be, in your mind, the ideal solution to that in order to be able to provide people care?
Oh my gosh, that's a great question. And I honestly don't know, right? I mean, I think I really do believe that there needs to be like a fundamental restructuring of our healthcare system in the US. But yeah, how do you get away from that, right? Because I mean, I can't really think of another thing in medicine that we use medications to treat, but that isn't really an illness, right? I mean, that's like our job. We see illnesses and disease and we diagnose them and we treat them. So I am not sure, to be frank with you. I think it would be, I think where it's moving and I think is useful is kind of restructuring what that diagnosis is and looks like. So right now we have the diagnosis of gender dysphoria in the DSM, and there are kind of a variety of criteria we use to diagnose that. It has to persist for at least 6 months. And I'm speaking about adults right now. Caring for trans kids is much more complicated and kind of beyond this conversation. But for adults, it has to last 6 months, and there are kind of a variety of criteria, right? Just like feeling like you do not identify with your sex assigned at birth, wanting secondary sex characteristics of a different gender, wanting to be perceived and treated as a different gender. And so I think potentially kind of changing how that diagnosis looks or what that diagnosis looks like could be a way to move forward. But yeah, since we have to prescribe medicine and perform surgery, I don't know that I see a way of moving away from that completely. It's really tricky.
It is. Can I ask a follow-on question?
Yeah.
So I know in the past there has been a requirement or a barrier if you were currently experiencing depression or other mental health conditions at the same time, that would actually prevent you from getting care. They would delay care. Is that still happening, and is that changing at all?
Absolutely. So I think that it is changing in terms of kind of how significant a mental illness has to be to prevent someone from accessing care. There is still a requirement that mental health conditions and certain medical conditions be relatively well controlled. right? And the particular language that is used is, I don't remember the exact quote, but it's essentially like that, relatively well controlled, right? Like if you have depression and are on an SSRI, but overall doing, functioning well, able to provide informed consent, then those types of conditions don't hold up accessing care, or they shouldn't hold up accessing care. We also we talked about how just existing as a trans person is really stressful and traumatic. And so most trans people have some sort of mental health diagnosis because of that. Where we really see this get tricky is that we now use mostly what's called an informed consent model, particularly in prescribing hormonal therapy. And so if your mental illness is so severe that it impacts your ability to provide informed consent, then of course it's not appropriate for us to provide that medical care at that time. And that's really where we delay. That's the circumstance where we would delay care, not out of a withholding treatment, but just waiting for it to be an appropriate time, and connecting people with, if you're somebody who can prescribe certain medications, you can treat depression, you can treat bipolar disorder, all of those things, or you can connect them with someone who can. Good question.
Other questions, comments? I do have a question for you, Dr. Jackson. Or someone in the chat said, could you talk about how to best approach neurodivergence as it appears in trans folks, and how this manifests as a barrier for receiving gender affirming care?
Absolutely. What an incredible question. I feel like people who are much smarter than me could talk for a very long time about this question. We definitely see kind of higher rates of neurodivergence among trans people compared to the general population. And kind of from an evidence-based medical framework, kind of unclear at this point why that is happening. My personal take, and I'll also say that my training before medicine was more from a sociology and gender studies background. And so I think that the way that people with neurodivergence, the way that their brain works is just so different from the way that, neurotypical people's brains work, that they kind of end up questioning some of those social constructs a lot more than neurotypical people do. Or they just have a very different way of relating to some of those social constructs, particularly gender and gender expression. And so we definitely see that some of the way they relate to gender is different than neurotypical trans people. And I think one of our jobs as healers often is to kind of ask people the right questions and interpret their answers, not necessarily at face value, but what they really mean. So a neurodivergent person might describe the way that they relate to their gender differently, but at the root, they're still saying I don't feel good in this body that I have, and I want it to look and feel different. And that should be kind of where our assessment is coming in, right? Is do you want your body to look and feel different so that you can exist in the way that you want to? And sometimes it's just a little bit more of a nuanced conversation. But I think in a lot of spaces does end up being a barrier if they don't kind of align with that typical trans narrative that a lot of people, a lot of providers want to hear from patients before they prescribe things.
Awesome. Other questions?
Do you have any suggestions on where people can go to learn more, such as maybe the 19th? News.
Yeah. So 19 News is a really cool news source that is predominantly like queer and trans run, where you can, they cover all kinds of topics, but I think they're very good at covering kind of like queer topics in news. So that's an awesome source. Medically, if people are interested in learning more, there are some really great webinars from the National LGBTQ Health, Health Equity, I think is the name. It's from the Fenway Institute, and KU actually has institutional access. There's like a code that you can get to be able to access all of those webinars for free. And for providers or for certain types of licensed people, there's CB that you can get from it. And Gigi Sayers is the person who could get you that code. I don't remember what it is off the top of my head. But they have a lot of excellent webinars about like providing healthcare, both kind of specifics about like hormone management or surgery, but also just how to do kind of like primary care or affirming care for like queer and trans folks.
Dr. Jackson, you mentioned interest in medical education. So if someone who went through medical school, where are some ideas that you can give us, all of us, on how to maybe, what type of content do you feel was missing or is missing, and how to better do that? I personally sometimes struggle with re-victimizing some of the students even through this conversation. So would love to hear your thoughts.
Yeah, absolutely. So this is really like a topic that hasn't been historically covered in medical curricula. It's like very new in a lot of places. Here at KU, a lot of other people have done, I am new to KU. I joined back in May. So other folks, particularly Meredith Gray and OBGYN, have really worked to like incorporate this into the medical school curriculum, which is excellent. At other institutions nationwide, it has been implemented in different ways. So here at KU, we have like a case-based learning in the second year where people do like a small group exercise as well as a large group lecture on kind of how to interact with trans folks and how to do some of the medical care. It's also scattered kind of throughout some of the clinical clerkships, depending on kind of who they rotate with. And should be included in like residency curricula as well. At other institutions, there are kind of standardized patient encounters with trans people in terms of like how to take a history appropriately. Really, I think in an ideal world, this would be kind of woven in with the rest of the medical curricula, because also queer people have all kinds of normal healthcare issues, right? Like, wouldn't it be great to see a case-based learning on hypertension where someone happens to be queer, but that actually has nothing to do with why they're getting healthcare, because we're just people. But I think that for those of us, who have already graduated, kind of seeking out some of those CME opportunities can be really useful. And we're seeing those included in like national conferences a lot, more and more, just depending on the particular organization. But yeah, definitely will require some work nationally to get this more incorporated for everybody.
Thank you.
Cool.
Any other final questions or comments? I have one more.
Sure.
Then how can you speak a little bit about how can medical providers who do not prescribe hormones or do surgery support this population?
Yeah, absolutely. So I think one of the big ones is just like gendering people appropriately, right? Making sure that every office, no matter your specialty, is asking people their gender and pronouns and the name that they want us to use. And just like being a safe space and a supportive space. making sure that like you as a provider, but also staff are trained so that, you know, if someone who is trans or gender non-conforming comes in, it's not a big deal, right? It's not like, oh God, what do we do? How do we ask this stuff, right? Like they're just a person coming in for healthcare. That is really one of the biggest things. The second big thing is that because these topics aren't covered in a lot of curricula, there's a lot of confusion and misconception out there about what they are and what they do and side effects. And so it is really common for other health conditions to be blamed on hormones or surgery or just because somebody's trans. And so I do think that it's important, whatever specialty you're in, to think critically about, is this actually a hormonally mediated process, right? Like if this disease presented in somebody whose ovaries made estrogen, would I blame it on their estrogen? And if not, like, why am I blaming it on this trans woman's estrogen? Just to like think critically about those things before you chalk something up to being caused by hormones or someone's identity.
Thank you. All right, one last chance for questions or comments. Well, thank you so much, Dr. Jackson. This was so informative. Thank you for your time and for sharing your knowledge with us.
Thank you for having me. I really appreciate the opportunity and hope you guys have a great day.
Yeah, thank you.